Hi, I'm Stacie Egan, Ogden Clinic GI. I'm a nurse practitioner working in general GI. I focus a lot on liver in my clinic, and so I'm excited tonight to talk about MASLD, MASH, and non-invasive testing. So first of all, I want to talk about MASLD versus MASH. Why does it matter? I think it's really important that we know the difference. So when you think of MASLD, you think of it as fat just sitting there in the liver, and it's not really anything necessarily dangerous. It maybe could be compared to something like clutter in your garage. It's annoying and maybe a fire hazard long term, but it's not actively damaging your garage right now. When you think of MASH instead of MASLD, you think of the clutter plus something actively damaging that garage. So it might be the fire. It might be someone actively swinging a sledgehammer in the garage, but it's active and it's damaging. So MASH can be thought of as active inflammation, ballooning of liver cells, and crucially, progression towards fibrosis and cirrhosis. And we do know that fibrosis is one of the biggest things when you're thinking about long-term outcomes for your patients. Fibrosis will lead to things like cirrhosis, hepatocellular carcinoma, liver transplant. And so it's important that we recognize the difference and we are willing to do what we need to do to find these patients and evaluate them, discover if they have MASLD, which progresses slowly, or MASH, which is the driver of fibrosis, cirrhosis, liver cancer, and other mortality. So it's sometimes difficult to distinguish between MASLD and MASH without some sort of additional testing. In the past, I think most people would get liver biopsies, but that is not what everyone does now. There are some non-invasive tests that we can do that allow us to make this distinction without jumping straight to biopsy. So what are non-invasive tests? There are tests that we can do through blood or imaging that help us determine whether or not our patient has MASH with fibrosis that aren't biopsies. So they're a little bit easier. They're a little bit more accessible for patients, and they're safer because patients don't have the risk of infection, hematomas, other things that can happen with biopsy. So it's not that biopsy is always wrong. It's just that non-invasive testing is sometimes the right first choice so that we can quantify and risk stratify our patients without doing an invasive procedure. So things that we can look at that give us a clue that our patient might have MASH, an elevated ALT. So when you're thinking about ALT, there's our normals on labs. But when I think about ALT, I always think a man's ALT should be less than 30 and a woman's ALT should be less than 20. If the ALT is higher than this, we have to think that our patient might have some inflammation in the liver. When we're thinking about imaging, a big thing that I think about is a fibroscan because I have that imaging in my clinic that's available to me. So a fibroscan uses elastography to quantify both fat and fibrosis. It's a really great way that you can assess your patient at bedside in your own clinic to figure out, do they have MASH with steatosis and fibrosis? This test can tell us. There are some issues with fibroscan, especially if you have a patient with a really high BMI, a patient who's actively drinking alcohol, a patient with really elevated AST, ALT, a patient that's not fasting. You might get a fibroscan score that's not quite correct, and you might need to use a different test. You could do something like an MRE for this patient to figure out fibrosis. It's another imaging modality that is a little bit harder to access because most clinics don't have this capability. The patients would have to be sent to the hospital to get this. It can be a little bit more expensive, and sometimes insurance companies don't cover it well, but it would be an option. There are some proprietary serum tests like ELF, which look at extracellular matrix turnover associated with active fibrosis. And this gives us a good idea if our patients have risk for advanced fibrosis. I will often use an ELF score if I have an initial non-invasive test that's inconclusive. I always think it's a good idea to use an algorithmic approach where you're using something like a FIB4 to first risk stratify your patients and then go on to another imaging modality or something different that would help you know if your patient has MASH with fibrosis. If they have MASH with fibrosis, I actively treat my patients with F2, F3 fibrosis. I think all of this should be, if you're not treating, you can refer to GI or hepatology to help with your patient's treatments. So when you're thinking about serum versus imaging, what is the right thing for your patients? There's so many options. Serum non-invasive tests are a great place to start just because they're so easy. And some of our tests like the FIB4, the NAFLD fibrosis score, the APRI are using labs that we already have. So there's no additional testing for our patients. There are some limitations to these testing. There are a lot of patients that are in the indeterminate range, and those patients always need a second test for fibrosis risk. But it's a good place to start, and it's a really good place for our primary care providers to start so that they know if patients need to get to someone in GI hepatology so that we can help them. So I do think that starting with a blood test, a serum test is a great way to start. It's easy and it's easy to do on a patient. Imaging NITs can be a little bit more accurate, but they do require specialized equipment and some of them can be more expensive. FibroScan is not actually a very expensive test. And if you do have access to FibroScan, it's a really great way to assess your patient for liver fibrosis and steatosis. You do have to have an operator who knows what they're doing so that your FibroScan can be accurate. And again, there's those patients that were limited with FibroScan, especially our patients with high BMIs, actively drinking, any sort of liver lesion. A FibroScan may not be the right test for them. But with a VCTE or a FibroScan, we can get both the KPA, which looks at stiffness, and the CAP score, which looks at steatosis. Anytime we're treating our patients with these new MASH drugs for fibrosis, we are addressing both of those things, fibrosis and steatosis. So it's good to know where our patients are when we're starting these medications. In fact, you wouldn't start these medications unless you knew they had MASH with F2, F3 fibrosis. So what's the takeaway? Start with serum NITs for broad screening and initial fibrosis risk stratification. And then if you have a patient that is indeterminate or higher risk, you can go on to a different modality that is an imaging modality so that you can figure out what your patient's fibrosis score is. It's a little bit harder to get your patients scheduled for imaging testing versus using these serum tests that you already have the labs for, but you can't just use the serum tests alone. So non-invasive tests aren't crystal balls. They're more like puzzle pieces. So say that you have a diabetic patient with a FIB4 of 1.2. When you're thinking of a FIB4, we know that less than 1.3 should be low risk, but this patient has an elevated ALT. It's a male and it's above 30. And we know that ALT has been slowly rising. They have other metabolic issues like hypertension, hyperlipidemia, maybe a family history of liver issues. I would never stop at that FIB4 for that patient. That's not the right thing to do. And we might be missing a patient that needs to be treated for MASH with fibrosis so that we can halt or reverse their fibrosis, which is what our goal is. Conversely, if you see an older patient, an 80-year-old with a FIB4 that's very high, we know that FIB4s can be elevated because of age and not liver disease. So we always have to look at the individual patients and use our clinical decision-making skills so that we're doing the right workup for the right patients so that they end up with the right diagnosis and treatment. We don't want to let these patients go back to primary care if they need to be treated for MASH with fibrosis. We actually want to treat, and now that we can treat, we should be treating. So patients that we need to look more closely at, any patient that has diabetes, they always have a higher MASH risk. So comorbidities like diabetes, obesity, hyperlipidemia, we need to make sure that we aren't just stopping at a FIB4, even though it says they might be low risk. We need to make sure that they really don't have anything else going on. If they do have ALTs that are increasing, we should look further into their liver to make sure they don't have MASH with fibrosis. If they have alcohol use in their history or a family history of cirrhosis, these are also patients that we probably want to look more closely at. I always treat patients that have F2, F3 fibrosis, and I closely monitor my patients with F4 fibrosis so that if they need to be referred to hepatology or transplant, I can do that. Even the patients with low risk FIB4 scores, I continue to monitor. I usually monitor yearly if they have any other comorbidities, which usually they do. So what are numbers that you need to know as an APP? So when you're thinking FIB4, which is an easy serum non-invasive test, low risk is less than 1.3. Of course, we've talked about patients that you need to take that with a grain of salt and maybe look further into the patient and make sure you're not missing something. Between 1.3 and 2.67, this is an indeterminate risk. Your patient needs an additional test like a fibroscan or an ELF test to see if they have a risk for advanced liver fibrosis. And then anyone over 2.67, we consider high risk. If you're managing MASH with fibrosis, you need to do something. If you're not, you need to refer them to hepatology for further workup. Another thing that you should really be aware of is fibroscan scores. So a KPA of less than 8, we consider normal. That's F0, F1 fibrosis. I usually continue to monitor these patients with a fibroscan yearly. I have access to fibroscans, so it's easy for me, and I'm able to know if fibrosis is progressing and if I need to start treating. If their KPA is 8 to 10, this is considered significant fibrosis, F2 fibrosis. These patients qualify for our new treatments, and I would start treatment on them with lifestyle modifications. I usually use a dietitian and get patients on an exercise program. These drugs aren't meant to be used alone. They always are meant to be used with these lifestyle modifications. If they have a KPA of 10 to 12, which is F3 fibrosis, these patients can also be treated with our new MASH with fibrosis drugs. Again, they're going to have pharmacotherapy and they're going to make some lifestyle changes, and we will continue to monitor them. If their KPA is higher than 15 on that fibroscan, they have, most likely they have cirrhosis or F4 fibrosis. They don't qualify for these drugs at this time, and so they need to be monitored long-term. They need the regular surveillance that we do, the every 6-month ultrasound. We need to be keeping track of their alpha-fetoprotein. We need to make sure that they don't need to be referred for transplant. There is that weird place between 12 kilopascals and 15 where we're not sure if the patient has F3, F4 fibrosis. This may be a time when we get an MRE or a liver biopsy. These patients actually may have F3 fibrosis that needs to be treated with one of these drugs. And so I think those patients always deserve and require additional testing, and maybe even with a biopsy. Just because we have non-invasive testing, it doesn't mean that we don't need to do other things like biopsies. So a final takeaway, NITs empower you to risk stratify your patient efficiently, but never ignore your patient's history. You need to make sure that you're identifying these patients that need additional treatment with pharmacotherapy or with lifestyle and exercise adjustments. So make sure that you're looking at these patients closely, that you're looking at your patients with metabolic syndrome and working them up further, and help these patients get the treatment they need so that they can reverse their MASH with fibrosis and live a long and healthy life with better outcomes. Thank you for coming tonight.